I am going to be talking on follicular lymphoma. Prashant, do stop me. Just let me know 5 minutes. Okay, right. So, follicular lymphoma, much has been already covered in the morning. So, selected demographics, second most common NHL, 15 to 20% of all diagnosed NHL, 5 year survival of 60 to 70%, average age of diagnosis 60 years. Quite often, it is associated with 14, 18, but that is not essential to cause a follicular lymphoma. Many of these patients could have a near normal lifespan like any other person. However, one must remember that the cause of death in follicular lymphoma still remains follicular lymphoma. It's not just any other cause. It's not old age. It's not other. It could be other cancers in a few, about 12% of the cases. Treatment related MDS, AML, or other treatment related problems in about 15% of the cases. But the lymphoma and its problems associated lymphoma remains the cause of death in follicular lymphoma. This has been discussed by Gaurav earlier. So we do the grading of these conditions, grade 1 and 2, like that is centroblast up till 15, 3A is more than 15, 3B sheets. Now, as far as management goes, 3B, one is very clear that these are treated like high-grade lymphomas. And for the purposes of this discussion, I'm going to be sticking to the indolent variety, which could be, the grade 1 and grade 2. There appears to be certain amount of discussion as far as what is 3, like 3 years should be treated as a high grade, whether it should be treated as an indolent. I think the consensus is that most of these cases are managed as a indolent lymphoma. We start staging. Of course, most of the patients that come to us will be the stage 3 or stage 4. Most of about 60% of these cases will be as such. A few of these cases will be stage 1 or stage 2. And how do we manage these cases? So when you look at the NCCN, so they club the stage 1 and stage 2 together. Now coming to stage 1, where there is just a single node, how do we manage these? So you've got an options. You've got options as excision. You've got option of observation. You've got an option of local radiation, and you've got an option of giving a systemic chemotherapy. What do you do? So for example, let's say pediatric type follicular lymphoma, those are usually localized, so that can be very well treated with just excision. Now coming to a neck node, you've taken a small neck node, you have removed it, that's it, that's gone, it's follicular lymphoma. Now do you treat this or do you observe? There are some data to suggest that such patients can also be kept under observation alone. Very small data, maximum number of patients 43 in the largest such series. So many of these patients, about 40% of such cases where you do just observation after removal of the node, they will come back, but then you can treat them again. Coming to radiotherapy, local radiation is fairly curative. However, are there certain situations where the radiation might not work or might be detrimental to the patient? So the radiation might be difficult in patient. It might not work as well if somebody has a bulky node. If it is more than 7 centimeters, then it may not work well. Or if it is in a certain location, like for example, in an intestinal area, it might not be safe. It might cause local problems. Yes, can we give safer ways of giving the radiation? Our radiotherapists are here. They say, yes, you can give, but that is a discussion for another topic. How much radiation? 24 gray, 2 gray fractions. Can you give less radiation? Like, for example, there are some studies to suggest 4 gray in 2 fractions. Yes, it can be done. Many of these patients do respond. However, the majority of the patients with 4 gray will have a progression of the disease, but it is possible. And then there are these patients like intestinal, large intestinal mass, single node. These kind of patients can be managed with a systemic therapy also. So you can give rituximab with any of the combination chemotherapies that you would like to do. Coming to stage 2 can be managed as a stage 1 only if you can localize all the nodes within one field. So if you can manage it within one field, you can give the local radiation. Otherwise, stage 2, stage 3, stage 4 are generally managed in that manner. We had a lot of discussion on PET-CT in the morning. So PET-CT is important, particularly to stage these, whether this is truly a stage 1 or not. So only if you are able to determine that this person is truly a stage 1 and you've done a bone marrow biopsy and confirmed that nothing else is there, then these patients, if you do a local radiation, then you could have a 5-year overall survival of 96%. I put up this slide just to show that if you look at the lower level here, this is a stage 2 patient. So they don't do as well with just a local radiation. Coming to stage 3 and stage 4, as many opinions as options. So we go for first line. These are all the preferred lines in alphabetical order. Bendamustine with obinutuzumab. You can even give it with rituximab. CHOP with rituximab or obinutuzumab. CVP, you can give with any of these. Lenalidomide with rituximab. Other recommended regimens, lenalidomide with obinutuzumab or even rituximab alone, weekly for 4 doses. First line therapy, for example, for certain elderly patients or infirm patients, you could give a rituximab alone, and then once they're relatively better in terms of performance status, you can shift to the other lines of therapy. Chlorambucil with rituximab or cyclophosphamide with rituximab. I have one patient of follicular lymphoma who started on chlorambucil just to debulk the disease. That lady has been there with me for 5 years just on chlorambucil. Of course, all of us have such anecdotal patients. Once you have given the initial treatment, then going to the first line consolidation, you could give either. So the NCCN allows you to give rituximab maintenance. Most of the studies are with 1 dose every 2 months for a total of 12 doses, but you can also give it, as per the NCCN, you can also give it, and that is what I also do in patients where I have given maintenance every 3 months for 2 years. You should definitely not exceed 2 years. Obinutuzumab maintenance has also been studied. I'll come to that later. And for other regimens, if they have been treated with a single agent rituximab, you can also give maintenance rituximab. Obviously, there are a lot of opinions on each of these, but these are all the standard accepted lines of therapy for your patient with a stage 3 or stage 4 follicular lymphoma. Once these patients have been treated, then you have to have the observation. They do the history and physical examination, laboratory examination like ESR and LDH, and then coming to the imaging. Of course, this is again another contentious issue. So here they have given the CT scan with contrast no more than every 6 months for a total of 2 years to begin with, and then annually you can do one more imaging just with the chest, abdomen, and pelvis. One of the experts that I listened to told a very nice thing. He said that one way to increase the progression-free survival of a patient with follicular lymphoma is to avoid your radiologist. So we don't. So I, as a practice, don't like to do imaging in patients with follicular lymphoma once I have treated them. Again, there are so it all boils down to your own individual experience. You will again listen to experts who have also found some of the cases with asymptomatic big mass in the abdomen, which could potentially be causing some target organ damage, but the patient is otherwise asymptomatic. So they suggest that some of these patients might be caught earlier if you are doing surveillance imaging. Again, as I said, multiple opinions. So one of the important things that you need to do now is to decide whether this person needs to be treated or not. And for that, you will need to know whether this person is symptomatic. You have got various criteria. Most of this is common sense, but one is the BNLI, the other is the JELF criteria. Basically, it just says whether the person is symptomatic because of the lymphoma or not. So the diameter of the tumor, more than 7 centimeters, systemic symptoms, substantial splenomegaly, any vital organ impairment, pleural effusions, ascites, cytopenias, whichever is, whatever that you could attribute to the follicular lymphoma and causing problems to the patient, you need to treat. So if you have got no indication, what do you do? If none of these are fitting in, if the person just has a couple of nodes here and there, not very large, you can observe. That is a category 1 recommendation in NCCN, which says that you can simply keep observing this patient and do the same kind of a follow-up as you do once you have treated a person. And once they start having some symptoms, you treat them. However, we do know that there are again other data which shows that if you give rituximab either as an induction followed by maintenance. So induction you give once a week for 4 weeks and then you do the maintenance as you do, or you just give rituximab induction and then leave the patient alone. These patients seem to have a better progression-free survival as compared to just observation. However, ultimately, the overall survival does not change. And that is the reason perhaps why NCCN does not recommend this. Now, coming to the RESORT study, this is rituximab maintenance in a group of indolent lymphomas, which included follicular lymphoma, mantle cell lymphoma, SLVL, all other lymphomas. And again, in these group of patients, if you look at the follicular lymphoma group, So if you are given the 3-year freedom from cytotoxic therapy in the maintenance group was better, treatment time to second treatment was better. So the progression-free survival was somewhat better in patients with follicular lymphoma. However, this data, as you can see yourself, is not very spectacular, but the results in the SLL and MZL group is significantly better. For example, in the SLL and MZL group, the time to treatment failure was just about 1.9 months in the retreatment group compared to 4 months or 5 months in the maintenance group. So possibly not for follicular lymphoma, but for other groups of patients, you may like to consider using maintenance. Again, once you have completed these patients who are asymptomatic, you can continue following them up in the same manner. This is the still study. So people always ask what to give. So stage 3 patient, stage 1 patient, large mass, what do you want to give? Do you want to give bendamustine? Do you want to give CHOP? Now, this is the still study where they gave rituximab, CHOP, rituximab, bendamustine in a group of indolent lymphoma patients. And here, if you look at it, bendamustine, rituximab was given, R-CHOP was given, and no maintenance was provided in this group of patients. So if you look at the outcomes here, median progression-free survival in bendamustine, rituximab was 69.5 months, compared to the R-CHOP, which was 31 months, progression-free survival not reached, 41 months here, and then the CR rates were better in patients with the bendamustine rituximab. And that is why most of the experts advocate that you must give bendamustine rituximab to your group of patients. This is the PRIMA study. Again, rituximab, do you want to give rituximab maintenance once you're given the R-CHOP and the bendamustine rituximab? So this study, please note, R-CHOP, R-CVP, R-FCM, no bendamustine rituximab. In these group of patients, if you're given rituximab, then possibly the estimated 6-year progression-free survival is 59.2 months. It is not correct to compare between trials. But if you looked at the previous still study, the median progression-free survival in the R-CHOP was just 31 months. Probably if you give maintenance, then it comes somewhat closer to what it is with the bendamustine rituximab. But if you're given bendamustine rituximab, there is some data to suggest that if you're going to give rituximab to this group of patients, you might be doing more harm than good. So at least in my practice, I do not give rituximab as a maintenance in those patients who have received bendamustine rituximab. This is the gallium trial, obinutuzumab, rituximab, 1,202 patients. Please note again, Gajiva with chemotherapy compared with rituximab alone, but here they continued Gajiva monotherapy every 2 months for up to 2 years. So, and again, what are the group chemotherapies given? Bendamustine based in the majority of the patients, 60%. The rest of the patients were getting either a CHOP or a CVP. And as expected, progression-free survival was better in the obinutuzumab-based therapy compared to the rituximab-based therapy. Overall survival was not any different. Again, I want to reiterate that if you're going to use obinutuzumab, I don't use obinutuzumab in my group of patients at first line, but if you're going to use obinutuzumab to get this progression-free survival, you have to give obinutuzumab as a maintenance, because that is what the trial showed. So all that good data, all that difference is primarily because of the maintenance. The other concern which that had come up earlier in the morning as well, when do you suspect a histological transformation? You've given all your therapy, you are now following up the patient. How do you suspect it? So you consider there is no single way that you can actually prove that a person has transformed. However, if the person has got some symptoms, if they've got LDH levels are rising, if a single site is growing disproportionately as compared to the others, if there's an extranodal disease, or there are B symptoms, you suspect that the person might have a histological transformation. May not be there, but you start suspecting. And finally, PET-CT, that was also discussed earlier, marked heterogeneity and intense avidity. This is again from the gallium study, they took out the data. So in this group of patients, there were just about 74 patients who had an SUV max of more than 20, and only 1 patient developed histological transformation. SUV max more than 13, 360 patients, only 3% developed a histological transformation. So baseline PET-CT does not predict whether a person is going to go into a histological transformation or not. Again another study, PET-CT baseline, where they gave CHOP. So R-CHOP was given in this group of patients. So it seems that if you give R-CHOP, you might be overcoming any baseline bad PET-CT that you're looking at, compared to the other group where all other chemotherapies were given. However, the rider to this particular slide is that many of these patients were also getting, in the other group, they were also getting single agent rituximab alone. So once you remove those group of patients, the differences are no longer there. So pod 24, you have been listening to pod 24 quite repeatedly all through the morning. There is currently, we can say that, okay, performance status is poor, male gender is there, beta 2 microglobulin is raised, LDH is raised. You are likely to be a pod 24 patient. However, having known that information, you currently do not have any biologically directed therapy. So you know that this is going to happen, but you can't actually change the therapy. You listen to M7 Flippy in Dr. Suryavansh's talk. So there are these 7 genetic markers in addition to all to the stage, the male gender, the beta 2 microglobulin, LDH. So you take many of these and you do the M7 Flippy. You can go online and do the calculation yourself. If you put it other than EZH2, which has a drug against it, EZH2 overcomes all others. So EZH2 is good risk. So if you have got any of these markers, but you have got EZH2 that seems to overcome these problems. So this is a clinical genetic risk model, which kind of stratifies all these patients and tells you whether the person is going to get pod 24 or not. How do you treat these patients? So again, the drugs are pretty much the same. We have got bendamustine, obinutuzumab. So if you have given bendamustine, rituximab earlier, now you give obinutuzumab with CHOP. If you have given CHOP with rituximab earlier, you now give obinutuzumab maybe with bendamustine. Lenalidomide with rituximab is again a good option. We have got then we have got rituximab again. If it is a delayed relapse, you can again pretty much start treating them in the same manner. But if you're given bendamustine earlier, please don't do it again. Though bendamustine is a good drug, even if let's say 4 or 5 years down the line the person is relapsing, if you're going to give bendamustine, you're probably just going to get more toxicities and not going to.
So we have 5 minutes more.
5 minutes more, great. So these are the data on pod 24. So 5-year survival, 50% in those patients. So if you've got an early relapse, then the options are limited. So you've got bendamustine obinutuzumab, CHOP obinutuzumab, and if they respond very well, then go on to transplant. But if they don't respond, then you've got the other line therapies like idelalisib and copanlisib. Autologous transplant versus allogenic transplant. Even though so as you can see, the non-relapse mortality is very high in cases of allogenic transplant. That is why even if there are good progression-free survival, the actual overall survival is the same. So autologous transplant is the way to go. Which patients to transplant? These would be pod 24, good risk, like, they're fit, and they should be within 1 year of getting the ETF. So you should try to get them into a complete remission within 1 year of the progression. And then these patients can do well on autologous transplant. This is the data from gadolin, which is Gajiva plus bendamustine. Of course, the progression-free survival is good. And then this is EZH2. This is basically a gain of function mutation, and for that you've got tagemetostat, which in those patients who respond, whether they're EZH2 negative or positive, the progression-free survival is the same. The only difference is that in those patients who are EZH2 positive, the CR rates are far better. This is the augment trial with lenalidomide, 12 cycles of lenalidomide with rituximab. And again, the progression-free survival was better, 39 months. And this is currently the only P31 phosphatidylinositol 3 kinase inhibitor that is currently available for use, that is copanlisib, and that again has a good median-free survival. We used to have other P3I, the other kinases available, but they have been withdrawn in 21 and 22 because of increased mortality. And of course, if you don't respond to any of these, you've got the car to the rescue. Prashant will be talking about that later on in the afternoon. We've got a Juma 5, again 91% overall survival, 74% complete response. And with the phase 2 ELARA, again 83% overall survival and 65% complete response. In this group of patients, please look at them. High tumor bulk, more than 3 prior therapies, pod 24 in 55%, prior transplant in 24%. This is the way to go. What about, and then again, this is the CRS, somewhat less with T-cell compared to axis-cell. The difference between autologous transplant and CAR-T. So autologous transplant, you need a chemosensitive disease. You need to have a complete remission prior to taking up for an autologous transplant. In a CAR-T, you don't need to do that. Of course, there are other toxicities compared in autologous. In CAR-T is primarily the B-cell aplasia and hypoglobulinemia. The other drug that we have discussed earlier again is the BiTE antibody. So we have got 2 of them. We have got the glofitamab and we have got a mosunetuzumab. The difference between the 2 is that glofitamab has got 2 sites for CD20 compared to mosunetuzumab, which is just 1 site. and mosunetuzumab has got a silenced FC portion. So because of that, the ADCC is less, and perhaps the toxicity is less. This is associated with a good overall response, 60% survival, 60% CR rates, and this could be used particularly when you may not be getting the CAR T earlier. They call it a mini CAR T. Then mosunetuzumab is also combined with lenalidomide because there is certain, the immunologic synapse is deficient in patients with follicular lymphoma that can be overcome by the lenalidomide. And because of this synergistic action, this is now currently being studied as a combination. So kind of summarizing my talk, follicular lymphoma, there are several opportunities because this is such an indolent and long disease, you have got lots of opportunities for a personalized therapy like no other disease. So you've got patient-specific factors like performance status, age, what is the patient, what are his goals of treatment? What are your goals of treatment? You kind of need to come midway. What is the toxicity tolerance for the patient? Disease-specific factors, histology, the stage, the tumor burden. And then, of course, we currently still have the areas of need that we need to have good biological factors which can help us determine the treatment. Thank you so much.
Nice talk. I just want to know about this gallium trial where they have used three arms of chemotherapy. So which arm showed the best results? If we R-CHOP, obinutuzumab, CHOP, obinutuzumab, bendamustine, or obinutuzumab CPT?
Sorry, I didn't get that part.
Sir, if we see the
So Dr. Mir is asking which arm out of these three had the best result, but the trial was not looking at it actually.
No, that was not looking at that data. That's right. Yeah.
Yeah, so BR still remains, the cornerstone. But in that trial, in the study you're mentioning, it was not looked at.
That was not what was looked for in that.
Mm-hmm. Yeah, but it's something worth looking at. I completely agree. Yeah. So that was the last question, actually.
Oh, great. Thank you.